Today we will discuss about the scalp. So scalp is basically the soft tissue which covers the clavia of the skull. It covers the skull. In this topic, what we will discuss will be the layers of the scalp, the nerve supply of the scalp, the blood supply of the scalp, the lymphatic drainage of the scalp, and some applied anatomy like the dangerous area of the scalp, the black eye, and the imagery vein we will also discuss in this topic. So, the soft tissue which covers the scalp is skull region is known as the scalp. Now, to know up to which extent this soft tissue is being covered on the skull region, only after knowing that we will come to know that what is the region of the skull which is being considered under the heading of the scalp. Now it extends from the supraorbital margin. In front, we have got this is the supraorbital margin. From here, this is the lower limit or the frontal limit of the scalp. Then it goes posteriorly up to the external occipital protuberance and the superior nuchal line over there. And on either side, it is the zygomatic arch. But this is not the true that the scalp region does not extend up to the zygomatic arch. It is actually that from the zygomatic region to the superior temporal line, this region is being considered as the temporal region. But the temporal region is also considered under the heading of the scalp region. So here we have got the front of the supraorbital margin. And here we have got the external superior nuchal line over here. And this one is the superior temporal line. Actually, this superior temporal line is the lower limit of the scalp on the either side. Here we have got a zygomatic arch. And up to this region, this region is being considered under the heading of the superficial temporal region. This will come under the heading of superficial temporal region. Now coming to the layers of the scalp, as we know that it is the layers of the scalp is the easiest to remember because each word of the scalp stand for the one layer of the name of that particular layer of the scalp. So we have got this S that stand for the skin, the C, the subcutaneous tissue or the subcutaneous tissue, the A, the aponeurosis, also known as the Gallia aponeurotica or the epicranial aponeurosis. Now we have got the fourth layer, which is known as the loose areolar tissue or the subaponeurotic tissue. And finally, we have got the pericranium, that is the periosteum of the skull, that is known as the pericranium, since we are dealing with the cranial region. So it is known as the pericranium. It is nothing but the outer periosteum. Now these are the layers of the scalp. See, this is the skin region. This is the cutaneous region. And this is the aponeurotic layer. And then we have got the loose areolar tissue. Then we have got the pericranium over here. And finally, we have got the cranial skull. We will talk about each and every layer. Now, first coming to the skin. Now, skin is, as usual, we know, except the palm and the sole, where we don't have the hair follicles. Here we have got the hair follicles, the sebaceous gland, and the sweat gland. Both the sebaceous gland are multiple over here. So you could see over there, this is the skin. This region is known as the skin. This is the region of the skin. And we have got the hair follicles over here. They are all the hair follicles. They are all the hair follicles over there. And in at the base of the hair follicles, what we will get the sweat gland and the sebaceous gland. Now coming to the connective tissue layer, the next layer, the second layer, that is the cutaneous layer or the subcutaneous tissue, is composed of the fibrofatty tissue. Number one. The most important thing that it contains the blood vessels and the nerve. The superficial blood vessels and the nerve is being situated in this layer. And it is very difficult to differentiate between the skin and the subcutaneous tissue. Both of them are merged like anything. There is a the skin attaches the epicene aponeurosis over here, and in between two, the subcutaneous tissue act as an anchor, and it attaches the skin to this one, and it consists of fibrofatty tissue. So the wall of the blood vessels, we have got the blood vessels over here. The blood vessels will be blood vessels is running like this. We have got the skin over here and the epicuneal aponeurosis over here. And in between two, we have got the fibrofatty tissue over here. Fibrofatty tissue over here. So what the fibrofatty tissue will do? This fibrofatty tissue over here, this will actually adhere to these blood vessels, or the blood vessel will adhere to the fibrofatty tissue. Blood vessel will adhere to the fibrofatty tissue. So this attachment of, or this adherence of the blood vessels to the fibrofatty tissue does not allow the blood vessels to contract whenever there is a sharp blow over the skull. Whenever there will be a sharp blow over the skull, this is the blood vessels does not undergo the normal phenomena of the vasoconstriction because of this attachment of this adherence of the fibrofatty tissue to the blood vessels, and this is a very important one. And so the minor scalp injury causes profuse bleeding. So the minor scalp bleeding, even the minor scalp bleeding will cause profuse bleeding, and the person always comes with the towel on his head to stop the bleeding. So to arrest the bleeding, we always apply the firm pressure over the underlying bone so that the bleeding could be stopped. So whenever there will be bleeding, it will be localized in the extent. Why it will be localized to the extent? And because of we have got the suture line. At each suture line, it will be stopped over there in this particular region. So we have got it will inflammatory will be painful, and there will be a good healing. Why there will be good healing? Because of the profuse blood supply over there. Now coming to the third layer, that is known as the aponeurosis, also known as the gallia aponeurotica or epicranial aponeurosis. It is also known as the gallia aponeurotica or epicranial aponeurosis. Epicranial aponeurosis. This aponeurotic layer, which is the third layer is like this. We have got the first layer over here. We have got the first layer over here. The third layer is like this. And what we have seen over there, that the subcutaneous tissue will be adhering to the skin to this one. But this gallia aponeurotica, this aponeurotic layer, it has got two muscles over there. This is the aponeurotic layer. This aponeurotic layer, it has got two muscles over there, one over here and one over here, and two on the front. Two on the front. So the back muscle is known as so it has got two muscles, occipitofrontalis and temporoparaetalis is this region which is not very much important. It is the occipitofrontalis which is holds the important role over here. So it has got two layers. This is the epicranial aponeurosis, and during the start of this lecture, what I have told that epicranial aponeurosis does not extend beyond the superior temporal line. If we are considering the zygomatic arch under the heading of the temporal region, under the heading of the scalp region, we have to mention that from the superior temporal line right up to the zygomatic arch, it is the superficial temporal region which comes under the heading of the scalp. So this is the superior temporal line. This one is the external occipital protuberance, and we have got the superior nuchal line. Actually, we have got posteriorly the external occipital protuberance. From the external occipital protuberance to transverse line, this is known as the superficial nuchal line. And above that, we have got the two more lines. This is known as the highest nuchal line. And there is a crest over here. This is called the external occipital crest going into the foramen magnum. We have got the foramen magnum over here. And this is the external occipital crest. And in the center, here we have got the middle of from the external occipital line to the foramen magnum. We draw the line. This is the external occipital crest. And the middle of the external occipital crest, there is again a transverse line. And this is known as the inferior nuchal line. This is known as the inferior nuchal line. So we have got two muscles over here. One is the frontal muscle. This is the frontalis, and we have got the two muscles of back. This is known as the occipitalis. So the origin of the occipitalis is from the external occipital protuberance and the highest superior nuchal line, not the highest nuchal line, and that too from the lateral aspect, not from the medial aspect. So there is a gap, and it get inserted to this apical aponeurosis. This is getting inserted into the apical aponeurosis. That means the occipitalis has got both origin and the insertion. And the origin is bony and insertion is the soft tissue. Here we have got the frontalis muscle, frontal legion muscle. But the frontal legion muscles did get intermingled with the orbital muscles. These get intermingled with the orbital muscles, and the corrugator supercilii, it get intermingled with this one. This one is this is the superior nuchal line over here, and we have got the occipitalis over here, and we have got this one. This is the reason we could separate that is only temporal muscles. We don't need to go through this one, and we have got the frontal muscles over here. We have got the frontal muscle over here. This is intermingled with the orbitalis muscle over there. So is a seat of the fibrous tissue. This is actually the fibrous tissue. It is aponeurosis, and it connects the occipitalis muscle to the frontalis muscle. In the front, it has got the frontalis muscle, and in the back, it has got occipitalis muscle, and in between the two, this is the epicranial aponeurosis. This is the epicranial aponeurosis. This is epicranial aponeurosis, and we have got the frontalis over here, and we have got the occipitalis over here. So now the extent of the epicranial aponeurosis, which is a very important one, and it is actually the extent of the epicranial aponeurosis which defines the extent of the scalp. So it extends to the external occipital protuberance and the highest nuchal line. It is not going to the superior nuchal line. It is a bit higher. It is coming to the highest nuchal line. And in front, it blends with the soft subcutaneous tissue of the root of the nose. It is not getting attached to the any bony part in the front region. It is getting attached to the root of the nose. Here it will get coming to this. And the side, it is a zygomatic arch. But it is not the apical aponeurosis which is coming up to the apical aponeurosis, but the few fibers may come. It is actually the temporal fossa which comes from the superficial temporal line up to the zygomatic arch. Now, since we have got this seat like this one, it has got anterior attachment, it has got posterior attachment. So, if there will be a vertical cut, we will cut it vertically what will happen? There will be no gap. The two things will pull each other, and there will be no gap over there. So this is to produce the gap. It is only the transverse cut. If transverse cut will be there, the two ends will be pull each other, and there will be a huge gap over there. So if cut transversely produce wound gap, there will be a gap of the wound. So this is the picture. We have got the skin. This one is the lateral view, the layers of the scalp. We have got the skin over here. See the subcutaneous tissue intermingled with, and this is the apical aponeuroses. And this apical aponeuroses actually going over here, and this one is the zygomatic arch. And it is this temporal fossa is actually coming up to the zygomatic arch, and it is not the apical aponeuroses which is coming up to the zygomatic arch. Now we have got the fourth layer. The fourth layer is the loose subaponeurotic tissue, and there is a potential space containing the imaginary vein. This layer is very important because here we will get the imaginary veins, and this imaginary veins you could see over here. This one is the fourth layer. We have got the imaginary vein over here. This is the imaginary veins over here. And these imaginary veins will connect the intracranial veins with the extracranial veins. It communicates the veins of the intracranial venous sinuses. This is the venous brain region. And here we have got the venous sinuses over here. And this venous sinus is actually connecting to the outer world with the help of this imaginary vein. This outer world is being connected with the world of imaginary vein. And the most important thing is that this imaginary vein does not contain any valves. So the fourth layer is known as the dangerous area. Why it will be called the dangerous area? You could see over there. This is the fourth layer, and the fourth layer containing. The fourth layer is having this imaginary vein. Fourth layer is having imaginary vein, and this imaginary vein is valveless. It does not contain valve. Its job is to maintain the pressure between the outer world and the inner world. Number one, but at the same time, since it is valveless, so what will happen? The infective agent or any notorious substances will come from the outer world to the inner world also. So that's why it becomes dangerous, as it causes the infection from the outer area to enter into the inner world. So this, the fourth layer, is known as the dangerous area of the scalp, and infection in the subaponeurotic space and with the pus collection release to the intracranial region because of the no valve in this. So we come to know that the three layers are joined together. Of the three layers, what we have got? This three layer, the skin, the subcutaneous tissue, and apical process. It is very difficult to differentiate between these three layers. This three layer is very difficult to differentiate, and they are known as the scalp proper layer. They are known as the scalp proper layer. But in the fourth layer, we have got the blood vessels, that is the imaginary vein, and which causes the infection, and that's why the fourth layer is known as the dangerous area. Now, the first three layer is known as the scalp proper layer. In the third layer, we have got the two muscles. Posteriorly, we have got the attachment on the bony attachment of the occipitofrontalis. Anteriorly, it is getting attached to the apical aponeuroses. Regarding the frontalis, we have got the attachment over. See the frontalis over here. The frontalis is being attached to the muscles, the frontalis muscles, the orbitalis muscle, the corrugator supercilii. So there is a potential space below the apical aponeurotic layer, and this is continuous up to the eye region. This is continuous up to the eye region. And this fourth layer is containing the blood vessels. So if there will be a bleeding over here, this bleeding could come very easily up to the eye region, and it will cause the black eye. It could come very easily with the over here, and it could cause the eyes. We have got the skin over here. We have got the apical epinosis over here. In this epiconotic layer, we have got the eyes over here. This is coming up to like this. We have got the fourth layer over here. And this, the blood vessels over there could come very easily over here. It could come very easily over here. So it will produce the black eyes. So the black eyes, if you blow on the skull, collection of blood in the subaponeurotic space and produces a swelling affecting the whole dome of the blood, the skull. The blood slowly gravitates into the eyelid because of the frontalis has got no bony attachment. If it could have the bony attachment, the blood could not, if frontalis attached over here, the blood could not extend below this one. But since it does not have the bony attachment, so below that there is a potential space, and through that space, the blood comes to the eye region and it produces the black eyes. Now, the safety, the valve hematoma of the cranial vault in the children with tearing of the durameter, and the fracture of the cranial vault in the children with the tearing of the durameter and the pericranium. The blood from the intracranial hemorrhage communicate with the subaponeurotic space or the fourth layer to the fractured line. The cerebral compression do not develop because of there is a gap over there. So if there will be the cranial vault will be fractured. The durameter is being punctured over here. The blood from the intracranial hemorrhage communicate with the subaponeurotic space over there, fourth layer. And through the fourth layer, it could gravitate to the lower region also. And that's why there will be no cerebral compression over there. There will be no cerebral compression over there. Now we have got the caput succeedum. That is the temporary swelling in the newborn. That is the edematous swelling condition of the skull proper due to the interference of the venous drainage while passing through the birth canal. So there will be a caput succeedum over here. Now coming to the fourth layer, that is called as the pericranium, is the outer periosteum of the skull. It is loosely covers the bone, and at the suture, it is continuous with the endocranium through the suture line. What happens over there? We have got the bone over here. We have got the suture over here. So the pericranium is actually, it is attached to this one, but at the suture line, it will come over here, and we have got the endocranium over here. We have got the endocranium over here. So this will attach to the endocranium. So at the suture line, this periosteum will go inside and it will get attached to the endocranium. Now we have got the cephalohematoma, that is the collection of the blood beneath the pericranium. The blood will be collected below the pericranium, that is the cephalohematoma. And this localized swelling, as you may relate the size of the related bone, because we have got if suture at the each bone level. So if we have got the periosteum over here, so the periosteum over here, periosteum over here, periosteum over here, and periosteum over here. So at this point, we have got the swelling of this. The frontal region, it will produce the size of the frontal region. Temporal region, it will produce the size of the temporal region. The hematoma will produce if in the parietal region, it will produce the size of the parietal region. Now coming to the arterial supply of the skull. So it has got the 5 sets of skull, the blood, that is the 3 in the front and 2 in the back. It is coming from the external carotid artery. You could see over there. This is the external carotid artery over here. And the internal carotid artery will inside. The scalp region is being supplied by both the branches of the internal cranial branch and the external cranial branches. So, out of the 5, the 2 indirectly from the internal carotid artery and 3 directly from the external carotid artery. Why indirectly? Because it is not the internal carotid artery which will give the direct branches, but through the branches of the internal carotid artery, the branches will come to supply this scalp region. So we have got the 3 frontal region. We have got the supratrochlear artery. We have got the superior orbital artery. Then we have got the superficial temporal artery. We have got the posterior auricular artery, and we have got the occipital artery. Of the 3, these 3, 1, 2, and 3, these are all the branches of the external cranial artery, external carotid artery, and these 2 are branches of the internal carotid artery. These 2 are branches of the external carotid artery. So we could say that the scalp is a potential site where there is an anastomosis between the external carotid artery and the internal carotid artery. In the front region, we have got the superior trochlear artery, the ophthalmic, which is the branch of ophthalmic artery. The superior orbital artery is the branch of the ophthalmic artery, which in turn is the branch of external carotid artery, and superficial temporal artery, which is a branch of the external carotid artery, which I have just told you. Now, the posterior auricular artery is a branch of external carotid artery, and occipital artery, which is a branch of external carotid artery. And this is the potential space where there is an anastomosis between the external carotid artery and the internal carotid artery. Now coming to the venous supply. The vein, as we know, that vein will follow the artery always. So we have got the superior trochlear artery, so we have got superior trochlear vein, supraorbital vein and the name is superior orbital vein. Superficial temporal artery, we have got superior temporal vein, posterior auricular artery and posterior auricular vein, occipital artery and occipital vein. Now, all the vein will do something and will merge somewhere else. So now we have got the superior trochlear artery and superior orbital artery. These 2 arteries will come together, and these 2 arteries will form the common facial vein. This will form the common facial vein. So this will form the facial vein. These two superior trochlear artery and superior artery will form the facial vein. Now we have got the superior temporal vein. This superior temporal vein is the superior temporal vein over there. This superior temporal is the superior temporal vein over there. And this will merge with the maxillary vein. And the maxillary vein, and to the merging with the maxillary vein, and this will form the retromandibular vein. Here you have got the retromandibular vein, and this retromandibular vein will divide into anterior and the posterior branches. The posterior branch will join the posterior auricular vein, and this will go to the external jugular vein. This will go to the external jugular vein. And the anterior division will join the facial vein to form the subclavian. We join to form the common facial vein. Sorry, this will join together to form the common facial vein, and this will go ultimately into the internal jugular vein. This will go to the internal jugular vein. This will go to the internal jugular vein. Anterior division of the retromandibular vein, we have got the supratrochlear vein and the superior orbital vein. This together forms the facial vein. Superior trochlear vein and superior orbital vein form the facial vein. This facial vein will continue forward, and we have got the superior temporal vein joining the maxillary vein in the parotid gland, maxillary vein, and this form the retromandibular vein, which will divide into 2, the posterior This is the retromandibular vein. This is the posterior division. This is the anterior division. This posterior division will join the posterior auricular vein and it will go to the external jugular vein. This anterior division will join the facial vein to form the common facial vein, and this will go to the internal jugular vein. Now coming to the imagery veins, we have got the two sets of imagery vein, the parietal imagery vein and the mastoid imagery veins. The parietal imagery vein, as the name suggests, it will enter through the parietal foramen, and occipital imagery vein will enter through the occipital. Mastoid imagery vein will enter through the mastoid foramen. So the mastoid foramen, and we can scalp with the sigmoid sinus. The one which will enter through the parietal vein will communicate with the superior sagittal sinus. We have got this one is the superior sagittal sinus region. This one, and this will continue two sets of there. One will communicate with the sigmoid sinus. This and other will communicate with the superior sagittal sinus, which is on the top. Next, we have got the diploic vein. This diploic vein is actually, this is the in between the two tables. We have got the two sets of diploic vein. We have frontal diploic vein and the occipital vein. There are all two more also, but the two important. The two are important. That is the frontal and the occipital. Occipital comes under the heading of both in the imagery vein and the diploic vein also. So we have got the two sets of veins. So one is the frontal through the superorbital notch and drain into the supraorbital vein, and the occipital diploic vein, it drain into the occipital vein by piercing the outer table and drain the transverse sinus by piercing the inner table. Actually, in between the two table of the skull bone, we have got the vein, and this vein is known as the diploic vein. And its job is to collect the blood, the newly formed blood into the circulation. So it collects the newly formed blood into the circulation. So imagery vein was connecting the outer world from the inner world, but the diploic vein is situated in between the two tables and it communicates the outer world from the inner world. Sorry, in between the two tables of the skull, and it actually carries the newly formed blood into the circulation. Now we come to the nerve supply. So again, the scalp has got everything in the terms of five sets. So we have got the 10 nerves on each side. We have got the 5 in front of auricle and 5 behind the auricle, 4 sensory and 1 motor. Its name is also the superior trochlear vein, the supraorbital vein. Then we have got the superficial temporal, it could be the zygomaticotemporal nerve. Then we have the temporal branch of the facial. And then we have got the auriculotemporal nerve. 1, 2, 3, 4. And the greater auricular nerve 5. 1, 2, 3, 4, 5. So they are the 5 nerves. And we have got behind, we have got the third occipital, greater occipital, lesser occipital, and posterior auricular nerve. Among all those 4 which we have just read now is the temporal branch of the facial nerve, which is actually motor. The remaining, the nerves, they are all sensory. So in front, we have got the superior trochlear nerve, supraorbital nerve, zygomaticotemporal nerve, and temporal branch of the facial nerve, which is a motor one. And auriculotemporal nerve over here. So behind the auricles, we have got the posterior branch of the greater auricular nerve, then the posterior auricular branch of the facial nerve, which is a motor one, which supply the occipital muscle, and the temporal branch. This temporal branch actually supply the frontalis muscle. And the lesser occipital nerve, the greater occipital nerve, and the third occipital nerve. These are the reasons. See the superior trochlear nerve, this is supraorbital nerve, and the zygomaticotemporal nerve. We have got the auriculotemporal nerve. These two are the branches of the ophthalmic nerve. This is branch of maxillary. This is branches of the mandibular. The branch of mandibular. And these are four. They are all the greater auricular nerve, C2, C3, cervical plexus. Lesser occipital C2, the cervical plexus. Greater occipital C2, cervical plexus. And third occipital C3, they are cervical plexus. So actually in the scalp region, we have got the arterial supply coming from both the internal cavity artery and external cavity artery. The venous drainage goes into the internal jugular vein and the external jugular vein. And the arterial supply, the nerve supply, the sensory is coming not only come from all the three divisions of the mandibular nerve, that is the trigeminal nerve, that is the frontal, the maxillary, and the mandibular nerve, and also from the cervical plexus. So, knowing the dermatome of the scalp region, it causes the dermatome undergo considerable overlap in the trigeminal and the cervical region. It is very difficult to differentiate the one dermatome of the dermatome means the area of the skin is being supplied by or from where the sensation is being carried away by the one particular nerve. Now it is very difficult to differentiate the actual boundary line between the one nerve and the other nerve. So it is very difficult for the surgeons also. So density of the subcutaneous tissue prevent the diffusion of local anesthesia. But it is that since it is quite dense, we have already just read about that. So diffusion of the local anesthesia will be difficult. So it is always preferred to do the surgery, the scalp region under the general anesthesia. Now, finally, we come into the lymphatic drainage of the scalp. So, anterior part of the scalp will drain into the preauricular lymph node. So, we have got the preauricular lymph node over here. So, the preauricular lymph node and the posterior part into the postauricular lymph node over here. This is the postauricular, they are the preauricular lymph node. So, what we have read in this chapter, that is the layers of the scalp, the nerve supply of the scalp, blood supply, the lymphatic drainage, and applied anatomy. We have dangerous area of the scalp. This is the fourth layer, the black eye. Why black eye? Because of the non-attachment, non-bony attachment of the frontalis muscles, causing the three layers to be become the one layer, and there is a potential space between the three layer and the fourth layer. And imaginary vein, the vein which is a valveless and which connects the outer world from the inner world.